Hello, and welcome to the Clinical Liver Diseases video series. CLD is an official digital learning publication of the AASLD. I am Chang, an assistant professor in Suncheonhyang University Seoul Hospital and the author of Optimal Modalities for HCC Surveillance in a High Incidence Region, publishing an issue, Asia Regional Issue of CLD. Question number 1. Do regional screening recommendations differ from guidelines? There are two major differences between the Western and Asian guidelines: the population under surveillance and the modalities for surveillance. All guidelines definitely recommend HCC surveillance in cirrhotic patients with TRIPU class A and B. But for non-cirrhotic patients, the recommendation grades differ among various guidelines. The AASLD and Asia Pacific guidelines recommend HCC surveillance in female over 50 years old, male over 40 years old, Africans over 20 years old, and patients with HCC family history among non-cirrhotic HBV patients. The EASL guideline additively states that non-cirrhotic F3 patients may be considered for surveillance based on individual risk assessments. The guidelines of South Korea and Japan further expand the population under HCC surveillance, encouraging surveillance in all non-cirrhotic HBV and HCV patients, regardless of their TRIPU class. Recommended levels of tumor markers also represent regional differences. The EASL guideline does not recommend testing tumor markers for routine surveillance, and the AASLD guideline states that AFP can be used in combination with ultrasound. On the other hand, Asia Pacific guideline recommends that combination of ultrasound and AFP measurement should be used as surveillance, and the Japanese guideline further recommends concomitant measurement of AFP, DCP, that is PIVKA2, and AFP L3 fraction with ultrasound. These regional diversities arise basically from the differences in prevalence and incidence of HCC. Cost-effectiveness studies have reported that an incidence of HCC exceeding 1.5% per year in cirrhotic patients and 0.2% per year in non-cirrhotic HBV patients would warrant HCC surveillance. Based on previous research, there are some differences in the guidelines of Europe, the United States, and Asia because the prevalence and incidence of HCC vary depending on the region. Question number 2. What about adapting CT or MRI for routine HCC surveillance? Ultrasound has been a standard radiologic modality for HCC surveillance, but recently, the performance of ultrasound to detect HCC has been considered suboptimal, particularly for cirrhotic patients who are at the highest risk of HCC. Therefore, a surveillance modality with both high sensitivity and specificity for detecting early-stage tumor is required in regions with a high incidence of HCC. In fact, a recent study has reported that the overall survival of cirrhotic patients at a high risk of HCC depends on the type of imaging modality used for surveillance. MRI-based surveillance showed a significantly higher HCC detection rate and lower false positive rate than ultrasound-based surveillance. Although the most sensitive modality enables tumor detection at an earlier stage and a higher chance of curative treatment, providers should also consider cost-effectiveness, accessibility, and potential risks associated with repeated exposure to contrast media and radiation. Question number 3. Are there any new modalities that can be used for HCC surveillance other than ultrasound or conventional CT or MRI? There have been several attempts to improve those shortcomings of CT or MRI for HCC surveillance. For example, a research on surveillance using low-dose abdominal CT is ongoing. Various abbreviated MRI protocols have been proposed to reduce cost and in-scanner time and eventually make MRI-based surveillance more cost-effective. Non-contrast MRI is also considered as a promising new surveillance tool. In addition, a combination strategy that alternates CT or MRI with ultrasound may be more useful in clinical practice. Further studies reflecting real-world practice are needed. On behalf of all of us on the CLD team, I hope you find this video useful. For more information about HCC surveillance in a high-incidence region, please visit us www.cldlearning.com. Thank you for watching.